دلوقتي مع الدكتور
And now we will come to the next speaker. Our speaker is Professor Ahmed Abdelmoity. He is Division Director, Neurology, Associate Chair, Department of Pediatrics, Chief of Epilepsy and Neurophysiology. He is a Professor of Pediatrics, University of Minnesota, Kansas City School of Medicine, USA. هيكون معنا دلوقتي دكتور أحمد عبدالمعطي through online Zoom meeting إن شاء الله. Welcome, Professor Abdelmoity.
Assalamu alaikum. First, I'd really like to thank the organizing committee for inviting me. It's a real honor and a real pleasure to be with my colleagues, my professors, and friends. And it's always gives me a lot of pleasure to be with you. Can you give me control of the slides, please, so I can share my screen? So it's always hard to follow suit after a great speaker like Dr. Yasser, and Dr. Yasser is not just a friend and a colleague. He's my professor. He's a brother to me, and I owe him a lot. So it puts me in a hard position to follow suit after a great speaker like Dr. Yasser. As Dr. Yasser mentioned, neonatal seizure really poses a big challenge in pediatric neurology and in the neonatal ICU, and a lot of times, if we were to dissect a little bit into neonatal seizures, we'll find that we have neonatal seizures are actually into multiple categories. There are many classifications classifying neonatal seizures by treatment, by age. Is it preterm? Is it post-term? And as Dr. Yasser alluded, the treatment will really to a big extent depend on what is it that I'm dealing with. And that's what I'm going to try to cover in the next 30 minutes or so. What's the clinical presentation? As pediatric neurologists, a lot of times we'll get a consult from the NICU saying the kid is shaking, or mom will say, you know what, he's doing some repetitive movement or stereotypic movement, something that can fall under a lot of categories. And to add to the complexity of that, if you look at the work by Kevin Staley, and I think Dr. Yasser alluded to that a little bit from Mass General, I cannot treat the same type of movement or the same even type of seizure after I confirm it's epilepsy with the same medication. And again, as an example, phenobarbital in a preterm baby will actually downregulate my glycine receptor, will downregulate my GABA, so it can be proconvulsant. So I do not want to use phenobarbital in a kid under 36 weeks of gestation. The opposite can be true. So it really starts with what is it that I'm dealing with. So I was privileged and honored to be the principal investigator of a multi-center study studying the clinical semiology. This was an NIH study. And just to highlight the importance of clinical classification, they dedicated $21 million over 3 years. So that was $7 million a year between 7 different centers. And again, I was honored to be the principal investigator of that, to be able to study what the clinical classification is. So to be able to get to what is it that we're going to do next. So as everybody knows, seizures can be a very first red flag or first sign of something wrong or something not right going on with the baby. So again, it can be sometimes treatable, as Dr. Yasser alluded, sometimes with early hypoxic ischemic encephalopathy, with cooling, and even sometimes with just giving it a little bit of time. Mizrahi, Rockaby, and Kellaway published series of studies showing that for those babies, 3 to 6 months of anti-seizure medications are going to be enough. I don't necessarily need to continue treatment all along. But again, it goes back to that first block. What is it? What kind of movement am I dealing with? Seizure can be the first symptom or sign. And again, as we all know, and as we teach our residents and our fellows, seizures are like fever. It can be because of a lot of reasons. Diagnosing seizure in itself doesn't give me the cause, but it might lead me to what next do I need to do. And sometimes the movement, if it's not seizures, it's not good news. It's actually bad news, because I might be dealing with severe hypoxic ischemic encephalopathy. I might be dealing with release phenomena inhibition. I might be dealing with some other movement disorders like dystonia or some other basal ganglia problems that can be even harder to treat than seizures. But again, I need to first figure out what kind of movement do I have so I can go to the next step with my treatment. This is not new, but the prevalence hasn't really changed. So if you look at that curve, so that shows the incidence, which are the number of new cases with neonatal seizure or with epilepsy in general that starts happening. So if you notice the first 2 years of life, which is the very left side of the curve, that's where the highest incidence. This is the highest number of new cases, especially in the first couple of months of life. That's when I have the most number of new cases of epilepsy being added to the epilepsy bucket. After that, the new cases continue to get less and less and less until I reach my 70s for a different set of reasons. Now I'm talking about malignancies. Now I'm talking about traumatic brain injury. I'm talking about strokes. That's when the incidence starts happening a little bit more. So if I identify early on, if I'm able to catch those neonatal seizures early on, I will be able to change the prevalence or the total number of epilepsy that's happening through that patient's life and that population's life. Okay, so enough of that. I'm going to be showing a lot of videos, so hopefully that's going to be fun. Bring your popcorn and get ready for some videos here. So I'm going to be going over pure clinical classification. I'm not going to be diving into etiology. I'm not going to be diving into treatment. Those are things to follow after I identify what's going on and what we ended up classifying it into: the focal clonic, focal tonic, myoclonic, spasms, generalized tonic, and motor automatism. And again, to be honest and to be 100% fair, a lot of that work was built on the grounds that were built with my previous mentors, Dr. Peter Kellaway, Eli Mizrahi, and Richard Rockaby, who put the very first foundation back in 1993 of the clinical classification, which we built back on back in 2015 and moving forward. So this is those are the three types of hypersynchrony, or the three types of hyperexcitability that can happen. So when it's epileptic, we know that we have it's like the gang, or it's like the mob. I have multiple bad guys or multiple bad electrical activity. For our neurophysiologists in the group, I have my PDS, my periodic depolarization shift, leading to my hypersynchrony, or that increased hyperexcitability. And this is what I'm going to get one of those three types of movements. And this is epileptic in all cases, as I'm going to show in the videos here. Sometimes I might have the hyperexcitability, which is different than hypersynchrony. So when hyperexcitability, this can be irritability, can happen with infection, can happen with HIE, can happen with some metabolic and genetic disorders. So with metabolic, again, depending on the level of involvement of the CNS, if I'm at a motor level or a cortical level, that's when I might have some focal. And again, those are more likely to be epileptic. If I'm a little bit lower beneath that in my neuroaxis, if I'm in the red nucleus or something that's subcortical, that's when my rubrospinal tract, and that's when all my inhibitory signals are being affected. It's going to be multifocal. It's going to be fragmented. It's going to be not following a specific pattern. And that's what I'm thinking more of. Okay, this is less likely epileptic. This is less likely seizures. It's serious. It needs a lot of attention, but I don't need to treat it with seizure medications. I need to take a look at the previous symposium, talking about spasticity, and talking about tone management, and talking about cooling, and so on and so forth. Whenever I am seeing the following category, which are in over 90% of those movements, and by the way, we had over 7,000 videos of babies having those movements, so to be able to come to those categorization. If it's a generalized tonic, in most cases, and I can never say 100% because there's always an exception, but in most cases, in the neonatal age group, I don't have the myelination, I don't have the connectivity to mount a fully generalized seizure. So that's when I see a fully generalized tonic, I'm thinking more this is a subcortical issue. This is not a seizure. This is more of a subcortical matter. Motor automatism is another less likely epileptic in nature. Okay, so let's go on and move on with the main focal clonic, which is going to be our first category, and that's how it gets categorized. So let's see some babies with some videos, and we're going to see in focal. The first type of focal is going to be unifocal, so it's happening only in one area. So in this young lady, she has this left upper extremity clonic uni-limb movement. So it's a one limb. It's focal. It is clonic in movement. And again, for everybody, I'm sure in the audience, we classify the seizure type not by the EEG, not by the etiology, by the clinical movement type. So in this, the categorization of this movement, given its timing, given its repetitivity, given its nature, this is clonic by all. And again, as you see next to it here on the EEG, you have this very nice right hemispheric, very rhythmic, high voltage, sharp and slow wave seizure. So this is your focal clonic uni-limb happening in one limb. In that young man here, if you'll notice that right side. And again, if you notice on the EEG, it's already happening, which can happen subclinical, which is notorious for babies or for neonates. Then I start seeing this clonic movement. So it's unifocal or uni-limb focal clonic. This is it's notorious. And actually, this was in 98% of the recorded babies. Whenever we saw this unifocal uni-limb, this was epileptic in nature. So when I see that in the NICU, when I have this in my clinic, this is obviously, we still go through the workup, we still go through the needed imaging and the needed metabolic or genetic or what have you, depending on the history. But in over 98%, any focal clonic uni-limb movement that was epileptic in nature. So again, those are some of the examples, and as you can tell, just looking at the diaper size, so this is, there you go, this is your clonic movement, very rhythmic, clonic in nature. As you can tell by the diaper size in those babies, some of those are actually premature babies, so they are not all term babies. Okay, moving along with the focal clonic, next is focal facial. So notice that eye, notice that eye with that focal clonic spasm or focal clonic movement. I don't want to call it blinking, not to confuse it with myoclonic, but also notice that the arm is moving. The arm is moving in a relatively different way, and this is part of. So it will happen with the clonic movement of the eye, followed by the arm, which is not uncommon because of that poor myelination. And this is obviously not to be described as generalized, and we'll talk about why in a second here. But this is when you have a focal clonic either in the eye and can be followed very closely by one of the limbs. Okay, so this young man here, and a lot of times this gets described as generalized, which if you notice, let's look at the left arm and the left leg, which are the ones moving. The right leg is, the right arm is really not moving. And just because his right side is connected to his left side, so this is compensatory movement. And this is to be differentiated from generalized. Babies at that age cannot have generalized seizures. And again, I'm going to say in most cases, because I can never say 100%. So notice this movement as well. If you look at the right side, this is where the seizure is happening. If you look at the left side, yes, it's moving because, again, the left side of the body is connected to the right side of the body, but that's compensatory movement. It is not part of the seizure. How do I know that? Look at the movements, how it's happening on one side. Then the opposite side of the body will follow suit. It's not gonna be the same. Okay, if we're still not convinced, the EEG will really give us the absolute slam dunk answer by showing that seizure coming out of that one focus. It is not gonna show me generalized spike and slow wave in a baby that's a neonate. And again, if you ever have a generalized spike and slow wave in a neonate, a true generalized, not a bilateral synchrony, please share it with me because I'd love to see that. This has not been described or has not been described in a wide range and a wide number of patients. Okay, so we're still in the focal clonic category. So next is multifocal alternating. So notice that. Let's first take a look on the EEG. So there are two seizures happening simultaneous. If you notice the timing, it's happening on the right and the left side. So if you know, and I apologize, the video quality here is not the greatest, but if you notice that right hand, it's going at a certain speed, but the left hand is going at a different speed. And again, we have to pay attention to what's happening first. And again, the EEG tells it very clearly, it is not synchronous. It's happening at two separate lines. So I need to make sure that I am not calling this generalized. If I call it generalized, I'm thinking more likely non-epileptic. This is multifocal clonic alternating. Again, whenever I have the irritability in that age, and this baby had a hypoxic ischemic encephalopathy, so I have the whole brain, the whole cortex is irritated, and that's why I'm going to have that multifocality. And it's not uncommon that multifocality will happen very close in timing to each other. Do I call it generalized? Absolutely not. This is multifocal clonic alternating. And sometimes the video or just looking at the baby without looking at the EEG might deceive me. But again, please keep in mind, the likelihood of generalized in that age group is very low. And just given the nature of the underlying pathology, it would absolutely make more sense for it to be multifocal as opposed to generalized. Okay, bilateral asynchronous. So notice that dancing baby here. So notice it's happening on the left and right. And again, this is not generalized, I promise you. And if you don't believe me, look at the EEG, please. This is asynchronous between the right and the left side. So this is asynchronous. Notice how it bounces. It's almost like a very quick ping pong ball going between the left and the right. So it is clonic, it is bilateral, but it's asynchronous. And the synchrony can be as low. The fastest asynchrony we could find in this whole study, over 7,000 babies, was 200 milliseconds. So it can be as little as 200 milliseconds, but those 200 milliseconds might not be easy to identify just looking at the baby. That's when an EEG can help me with that. But this is another example. Look at the left and the right side. They're not at the same. So the left will go, then the right will follow right away. So it's a multifocal. It is clonic because that's the nature of the movement, as we agreed. It's bilateral, happening on the left and the right side, and it is 100% asynchronous. So I cannot call this generalized. Again, are we splitting hairs here? Are we really talking just semantics? No, we're not, because if I call it generalized, I'm going to show you some generalized movements here in a minute. I have to think of a completely different category. I have to think of a completely different workup and a completely different treatment plan. Okay, migrating. And this is, and I'm not necessarily talking about malignant migrating epilepsy of infancy. This is a category that's been identified on its own, that has its own different workup and treatment. I'm talking about just a simple migration. If you would, it's almost similar to Jacksonian march, just without having that Jacksonian march feel to it. So this young lady, so notice her left lower extremity. So that's where it starts. Then you notice a little bit, she's going to start having that left side and the right side. And again, now everything is shaking. Is that generalized? Absolutely not. It is focal. It started focal, and I have it multifocal. As we always know, and as we always teach our residents and our students, that we do not care how the seizure ends. We only care how the seizure starts. The seizure can always end into a bilateral tonic-clonic. We only care how the seizure started, and in this case, it was very clearly focal. And again, the nature of it is clonic, and it is migrating because it went from one spot to the next to the next. It is not what used to be called secondary generalized, which now is called bilateral tonic-clonic, because he doesn't have that kind of myelination. Notice the foot. And now notice a little bit of the hand. So it migrated, and it's going from one limb to the next limb. Notice that finger, that very different frequency, subtle clonic movements that's happening on that left finger. And again, my EEG is showing me it's exactly time locked. Obviously, the EEG is horrible. You have suppression, you have asynchrony, you have a discontinuity. So it's a very, very encephalopathic baby. So they can have anything. But again, classifying the movements from a semiology, from an epilepsy semiology standpoint, that's the multifocal clonic migrating. Again, notice that left big toe and the left left lower extremity, that I'm having some movement over upper and lower extremity, and the EEG even followed that. So the EEG was going over that left hemisphere, then it started going over to bilateral sides, and now it's migrated. It stopped in the leg, it migrated to the arm, and now it's the bilateral extremities. And again, the EEG is agreeing with that. It's showing my high voltage, rather delta focal slowing, which is, in that case, that was the kid's epilepsy signature. Okay, last type of focal clonic is axial, whenever it's in the midline, and most of those are actually in the tongue. So and this is one of the very rare types of epilepsy when you have tonic tongue protrusion, and typically happens in the neonatal age. So notice he's doing all sorts of different movements with his upper extremities. Again, remember, this is an encephalopathic baby who has a lot of release inhibition going through my rubrospinal tract, going through my red nucleus. But if you notice that tongue protrusion, it was in a clonic movement, it was axial, it was in the midline, and the EEG agreed 100% with it, that it was coming out of that right hemisphere with that rhythmic activity. I'm going to shift gears from the clonic, and I'm going to move to the focal tonic. And again, with those, they're most likely are going to be epileptic in nature. So we're still in the epilepsy or the seizure side of things. So notice that young man as he is feeding, and notice all of a sudden he's going to stop feeding, and he's going to have tonic eye deviation. So notice that left tonic eye deviation, and it's really nicely correlating with that buildup on the EEG on his right hemisphere. Then it can start again. So this is very subtle, and this is where our great neonatal ICU nursing can really be of help, and obviously really parents who can pay attention. So the seizure is still happening. So it's a tonic eye gaze or a tonic eye deviation, and this is my focal tonic ocular. By the way, this is one of the most common neonatal seizure types, as subtle as it is. And it's also one of the most missed neonatal seizure types. So notice those little clonic movements on the left upper extremity, but also notice the eyes. So the eyes are tonically deviated to the right side. And again, this is where you see the EEG nice seizure building up. So he has a little bit of clonic movements over his left upper extremity, and that nice tonic eye deviation over to the right side. So if I were to classify that again, this is the tonic eye movement, but also this is a multifocal, which in that age group, sometimes you'll see on the EEG, which is fascinating, you'll see 2, sometimes even 3 seizures happening at the same time from 3 different foci. Tonic limb posture. Notice that left upper extremity, that very nice, persistent, sustained posture of the left upper extremity. Look at that. And now I have my very nice tonic. This is tonic. It has no clonic movements part to it. Towards the end, he's going to have a couple of clonic movements, but it's for the most part, it is a tonic seizure. And again, the EEG is 100% agreeing with it, with that left hemispheric high voltage sharp wave activity. Okay, so my next is my focal tonic asymmetric hemi posture. And again, the reason I really want to point the attention to the hemi posture, because you'll see the whole body will move. It doesn't mean it's generalized. So in this case, again, fortunately or unfortunately, the right side of the body is attached to the left side of the body, so it will move with it. But it's a compensatory movement. It is not a focal seizure in its own. So this is my focal tonic. So again, it's a hemi posture. It's in the middle of the body. And yes, you'll see some clonic movements with it, but the hallmark of that seizure or the hallmark of the movement is that tonic phase or that tonic posture that the kid is having. Okay, so far we talked about the clonic seizures, the focal clonic seizures with all its different types. We talked about the tonic seizures with all its different types. Let's move a little bit to the myoclonic, and this is where it gets a little bit confusing because it can be either or. And those are usually the ones that are a little bit more challenging because, number one, they happen with a lot of different etiologies. It can be cortical or subcortical. It can also be related to some other causes that might be non-neurological, something systematic, like kids with hepatic encephalopathy, kids with elevated ammonia, and so forth. So it can be because of number of different reasons. So honestly, when we were collecting the data, when we were reviewing all those thousands of EEGs and thousands of videos, this is the one that gave us the most challenge, and that's where we actually, as a group, we ended up agreeing that for focal, it is usually epileptic, and actually it was a 78%. Whenever you see focal myoclonic, I'm going to show you some examples of that, it's going to be epileptic. When it's multifocal fragmentary, it was only 17% that was epileptic. So which means the majority, if I see multifocal fragmented myoclonic event, then it's most likely non-epileptic. Whenever it's generalized, like we agreed, when it's true generalized, and again, I know everybody here is an expert in that and knows that very, very well. I have to really stop and pause and ask myself, not just by the EEG, but by the clinical semiology, is that a true generalized or is that a compensatory movement that the baby is doing? So this, if it's truly generalized movement, it's non-epileptic and 99%. Actually, there was one child that had it that was iffy, and that's exactly why we would have loved to call it 100%, but we could not because of that one child that actually ended up having questionable seizure that we debated a lot about it, which again, I'm not going to go over that. So again, that's a description of your myoclonic twitches. You all know that. It's something that's fragmented. It can be focal, it can be multifocal, it can be fragmented, it can be asynchronous most of the time. And again, typically not repetitive. And that's the challenge. If you think of your Otohara syndrome babies, or if you think of your Dravet syndrome babies, those typically are very fragmented. They really come left and right. If you think of your GLUT1 transport, severe GLUT1 transport deficiency early on, which sometimes can present in the neonatal age group, those babies the myoclonics are very fragmented. They do not follow a specific pattern. It can be all over the place. So notice that left arm, because it's going to be very quick. Notice that left arm. There you go. And notice the EEG, it did have that very time-locked seizure with it. So it's a myoclonic focal. And again, it will take that, that attention. Obviously, those babies, they have a lot of things going on. So they have disrupted sleep. They have problems with feeding. They have sometimes, a lot of times actually tone problems. If it's early on, it's going to be flaccidity or hypotonia. Later on, they're going to develop spasticity or rigidity. Notice that one. So notice that upper and lower extremity fragmented. The EEG is abnormal in an encephalopathic pattern, but non-epileptic pattern. There's not a single spike correlating with those movements. So if it's fragmented, if it's multifocal, if it's a myoclonic, I am thinking non-epileptic. This baby needs care, needs treatment, but maybe he needs treatment through cooling, needs treatment through tone management, not anti-seizure medications. And the biggest problem that we see happening, sometimes even in the United States, a baby like that will end up getting phenobarbital, as Dr. Awad just mentioned. But so you take a baby who does not have seizures, who obviously has a very encephalopathic bad brain, and I give him phenobarbital because I'm thinking those are seizures. So I just switched what was not epileptic into what now is epileptic. Because remember, phenobarbital in a preterm baby under 36 weeks of age, it actually downregulates my glycine receptors and it downregulates my GABA. So which means what? Which means it actually is proconvulsant or can cause seizures in this preterm age if the baby has already an underlying encephalopathy. So again, all those videos, as you can tell, this was a 27-weeker with that kind of generalized fragmented movements. This is not seizure. Again, it's bad news. Probably I would rather seizures over this, because this, I mean, seizures I can treat with anti-seizure medications. This, it means bad news. This baby is going to probably, as you can tell, if they're already intubated, it's probably going to need a tracheostomy down the road. It's going to need most likely mechanical ventilation. It's going to need G-tube. He's going to need spasticity management, movement disorder management. So it is not seizures, which is not good news, but it needs a different type of treatment. Here's my myoclonic, and I'm about to finish here to keep us on time. Here's my myoclonic generalized. As you can see, this is myoclonic generalized, are not seizures, as I said, in over 99%. Look at that EEG before even you look at the baby. This is almost flat. It's a really encephalopathic baby. But those quick, brief myoclonus, I am losing the control over my muscle inhibition. That's part of the hypoxic ischemic encephalopathy. So this is subcortical myoclonic movements that I have to categorize. I do not treat those with seizure medications. Yes, this baby, by the way, might have a different type of seizure. Great, I'm going to treat it. But for this particular movement, or if this is the only type of movement they're having, generalized myoclonic, those are not seizures. Epileptic spasms, formerly known as infantile spasms, and everybody knows why they changed the term back in 2017. You know, those are the different types: my flexor, my extensor, my mixed flexor extensor, and those are relatively easy to diagnose given the look at that. This is my, it's almost like typically under 2 seconds, very brief. It's actually myoclonic / tonic phase. So if I dissect any spasm, it starts with my very brief myoclonic, then my tonic phase, typically under 2 seconds. Some babies will have a more pronounced myoclonic and a very brief tonic phase. Some other babies will have the very opposite. So I'm going to have a very subtle myoclonic, like this baby that I just showed you, and the brief tonic. So it's a component of both. If I actually were to replay 1,000 videos of spasms of all different ages, you're going to always see that two components of a spasm, which is, again, by definition, it's that myoclonic tonic brief movement. Those are what I call the dancing babies. So those are the non-epileptic features. Those are typically either generalized, extensor, flexor, a repetitive movement, automatism. Notice that cheerleader here. She's going to start moving relatively more automatism, random movements. Notice that left lower extremity. You're going to notice a little bit of cheering here in a minute. And again, nothing really on the EEG. Notice that. See that generalized again with, hey, I'm cheering. She probably is cheering for her favorite team here, but so again, generalized tonic, it's not going to be seizures. I cannot mount a true generalized seizure. Again, please differentiate this from the earlier videos that I showed you. That's hemiconvulsive or that's hemitonic with compulsory movements. This is pure generalized. So same thing, generalized tonic. There's no EEG changes with it. The baby is encephalopathic, awake, but those are definitely not seizure because they start from the get-go as being generalized. The motor automatism, and again, this is another sign of encephalopathy, but not a sign of epilepsy. Can be oral, can be lingual, can be ocular. It's repetitive movements, blinking, sucking, and honestly, those are the ones that are hard to differentiate. And I need to get an EEG, preferably while the event is happening, to be able to tell what's going on. Some of the clinical signs, if the baby stops their feeding, if the baby stops what they're doing, if they cannot follow suit, if they're old enough to be able to follow my cue, those put me a little bit more on the epilepsy side. But those are the hardest, and a lot of times I'm going to need a bedside EEG to be able to diagnose and differentiate what's going on with them. Again, same thing, doc. Any of the automatism movements, they progress or they can progress, which is another sign. They typically are very fragmented. They're rapid. They're not well organized. They're very random. They are not necessarily related to a specific sleep or wakeful pattern. And that's where, again, cannot 100% say what they are without an EEG, but they're more likely to become non-epileptic in nature. So let's see a few examples of that. So this is ocular motor automatism. So the eyes are roving left and right. By the way, things that cross the midline are very unlikely to be seizures, and that holds true for adults, holds true for older children. If my eyes are roving left all the way from left to all the way right, I'm thinking something else. I'm thinking something that has to do with my brainstem, something has to do with my subcortical structures, but very unlikely for it to be seizures. Same thing. This is another example of oral-buccal. Notice the tongue. So those are the chewing movements. Some chewing and sucking movements that are happening, which are different from the axial tonic that I showed you. Remember the axial tonic? I'm sorry, the axial clonic was the tongue was protruding in a very rhythmic way. This is different. The baby is doing some chewing movements, oral-buccal-lingual. Sometimes the tongue is going from left to right, anything all the way left to all the way right. It's impossible for it to be seizure in that age group because, again, if you think of your homunculus, if you think of your connectivity, I don't have any connection to jump from my right to left premotor area or from my left to right precentral sulcus, precentral gyrus that way. So I have to be in a non-epileptic area. I think that's my last video here. Some more motor automatism. Notice that. This is very fragmented. By the way, what you see in the EEG here, this is on the same side where the baby's head is falling. This is clearly an artifact. It doesn't really follow any specific pattern. It's roving. It's rotatory movements. It's coming from the shoulder. So it's a big joint and a rotatory movement, very fragmented. Flexor, extensor. So I cannot really place it even from localization standpoint, as all of you know, are experts in anything in neurology. I have to first localize before I do anything else. Where would I localize this movement? It's non-localizable. So I mean non-cortical localizable. So this is a subcortical. This is not a cortical localizable movement. And again, this is my limb movement progression. It can progress. It's very asynchronous, very non-rhythmic, very fragmented. The baby is crying during it, so obviously he's awake. It's happening left and right. And so those are automatism, limb automatism that can happen in the upper extremity, lower extremity. As I showed you, can happen in the eyes, can happen in the mouth, and the lips, and so forth. So this is, I believe, my last slide. So this is the full classification as we put it all back together. My focal clonic with its types, my focal tonic, myoclonic, spasms, then going over the less likely epileptic, my myoclonic, my generalized tonic with its different types, my motor automatism, and again, my electrical seizures to add. So I know Dr. Awad spoke to that, so I'm not going to go over, but those are the most common causes of neonatal seizures. So again, it's a real honor, and I'm really privileged to be with you today. And again, thanks again to the organizing committee, and it really made my year to be with my professors, friends, and colleagues here. Thank you very much.
Thank you very much, Professor Abdelmoity, for being today with us and for your very nice and illustrating videos concerning the types of neonatal seizures. Thanks a lot.
Thank you. السلام عليكم ورحمة الله وبركاته. احنا دلوقتي بقى في السبيكر الأخير في الجلسة بتاعتنا، الأستاذة الدكتورة أمنية فتحي رشيدي. أنا الحقيقة لازم أشكرها على الدعوة الكريمة، وأشكر أستاذي الأستاذ الدكتور حامد الخياط وأستاذة الدكتورة سحر وكل زملائي وأحبابي في البيدياتريك نيورولوجي.
If anyone have questions for Professor Abdelmoity before leaving us online? Any questions? Okay. You have? Professor Abdelmoity? Are you still with us? You went?
No, I'm still here.
Any question for Professor Abdelmoity? He's still with us online. Any question for him? Okay, Professor Hoda has a question. Okay.
شكرا دكتور احمد بيه. سؤال صغير كده، حضرتك صعبت المساله علينا، ما سهلتهاش خالص. الى اي مدى كان الاي اي جي له دور في ان حضرتك يعني بتوصفها وحضرتك واثق؟ ده اول سؤال. يعني هل حضرتك كلينيكالي تقدر ديفينتلي تقول؟ وتاني سؤال، ايه تجربه حضرتك مع الهايبر اكيبلكسيا في السن ده؟ بيبقى شكلهم عامل ازاي؟ احنا كان عندنا ديبيت انا والدكتوره رانيا على شكل عينين للهايبر اكيبلكسيا في السن ده. شكرا.
اولا عفوا ان انا صعبتها، that wasn't my intention، ولكن هو neonatal seizures and neonatal epilepsy و neonatal movements in itself it's a whole field. ويعني عشان نعطيها حقها that زي ما حضراتكم عارفين there are whole conferences just for neonatal seizures and neonatal movements. ف it really starts with the clinical semiology. ده أول حاجة الواحد بيفكر فيها. في broad lines categories زي ما اتفقنا، حاجة repetitive focal clonic أو focal tonic، يعني ما بفكرش مرتين، ده بيكون epileptic. الحاجات اللي هي بتكون generalized وبتكون myoclonic، ده اللي محتاج استعين بصديق، والصديق في الحالة دي بيكون عادة بيكون EEG. ف I cannot diagnose epilepsy in pieces. Epilepsy is like reading a book. I cannot make up my mind about a book. ما ينفعش اكتب تقييم لكتاب وانا في نص الصفحه، او انا في نص، او اقرا 2 chapters من النص. فضروري الهيستوري، الاكزام، السيميولوجي، الاي اي جي، الصوره كلها هي اللي تقدر تديني الخلفيه العيان ده ايه اللي عنده. فاحنا خدنا جزئيه صغيره جدا من القصه كلها اللي اتكلمنا عليها النهارده، وهي السيميولوجي. السيميولوجي بيديني صوره كبيره جدا، ولكن مش هو لوحده. ما ينفعش ابدا استعين بس بالسيميولوجي واشخص بناء عليه. عشان كده دايما الاي اي جي بيكون صديق الحميم في اي ابيلابسي كيس، بالاخص في النيوناتال سيجرز. فيعني الموضوع مش صعب، او بمعنى اصح الموضوع محتاج بروتوكول او محتاج الجوريثم. انا هشخص بناء على ايه؟ بناء على محتاج الهيستوري، محتاج الاي اي جي ضروري بتاعي، خصوصا في النيوناتال سيجر. حتى لو انا العيان ده خلينا نقول ان عنده او ما عندوش ابيلابسي، لو العيان ده هايباكسيسكيميك انسفالوباثي وهعمل له كولينج، طب ما انا عشان اعمل له كولينج انا محتاج له، لو هنتكلم بروتوكول مظبوط according to the ACNS، انا محتاج اعمل له continuous EG وانا بعمل له كولينج عشان اكابتشر لو في سب كلينيكال سيجرز اللي احنا عارفين لو بتحصل، وانا مش هقدر اشوفها بقى، بنتكلم حاجه سب كلينيكال، هتفرق جامد جدا في الليتر اون ديفلوبمنت وفي الديفلوبمنت اوف ابيلابسي بتاعي. فانا ضروري بحط كل حاجه مع بعضها، ما ينفعش ان انا ابص فقط على السيميولوجي واقول خلاص انا هشخص بناء على كده. فما اعرفش ده صعبها زياده يا دكتوره ولا اجاب على سؤال حضرتك، لكن مهم جدا ان انا احط كل الكومبوننتس مع بعضهم السيميولوجي عاده بيكون نمره واحد بعد الهيستوري. طبعا الهيستوري باخد الهيستوري بتاعي، بس السيميولوجي بيفرق لي جامد جدا جدا جدا. على فكره السيميولوجي كتير جدا من الحاجات اللي وريتها لحضراتكم. ساعات لو الام او حتى الممرضه في النيكي بتصور الطفل بالتليفون، بقدر اعرف الى حد كبير قوي انا في اني كاتيجوري. يعني هل محتاج حتى امبيريكلي ابدا ليفوترستام او ابدا بريفراستام او حاجه لحد ما اقدر اخد بقيه الهيستوري، ولا لا دي حاجه completely non epileptic عشان الفيتشرز اللي احنا اتكلمنا عليها.
Next question, second question for you, Professor Abdelmoity, دكتورة سحر حسنين.
شكرا دكتور احمد، دي مش اول مره نتقابل وبستمتع جدا لما بشوف مع حضرتك النيونيتال اي جي. السؤال احنا عندنا فعلا بنحط الاولاد على اي جي اثناء الهايبوثيرميا. ايه الرول بقى بتاع الاي جي اثناء الهايبوثيرميا والباراليسيس اللي بيتعمل بالنسبه للطفل؟
هو حضرتك الاي اي جي الكونتينيوس اي جي لما بعمل هايبوثيرميا، وزي ما حضراتكم عارفين طبعا لما بعمل هايبوثيرميا الاكيورسي بتاع اي اي جي اول ما بنزل beneath ال 32 degrees ما بيبقاش the same. ولكن الرول اوف اي جي هنا عشان يكابتشر اني سب كلينيكال سيجرز واقدر اتريت. انا مش بالضروره بارالايز الهايبوثيرميك بيبيز، ولكن الاهم حاجه ان انا بايدنتيفاي وتريت سب كلينيكال سيجرز. الليترشر مختلف، في من اول 23% لحد حوالي 40% من السيريز بتاعت النيوناتال اي جيز during hypothermia showed subclinical seizures. لما تابعوا البيبيز دول up to 15 years بعد الهايبوثيرميا، المجموعه اللي كانت treated for their subclinical seizures had a much better development and a much less epilepsy percentage عن المجموعه اللي ما كانتش followed by EEG. فالرول of EEG during hypothermia is فقط حاجه واحده to detect any subclinical seizures with a treat it early on.
Okay, so just a reminder that Professor Hoda Tmoum had the second question. So I'm going to ask you, how about hyperepilepsy in neonate, please?
Yeah, so hyperepilepsy, and again, this is another area. Hyperepilepsy can happen. It's more common to happen in a little bit older babies. ولكن بنشوفها في النيونيتس. وفي أحيان كتيرة جدا بيكون ال EEG هو الفيصل. في بعض حالات الهايبرإبلكسيا زي مثلا في حالات النانكيتاريك هايبرجلايسينيميا بتكون المايكلونيك بيكون very rapid, very fragmented, bilateral, almost in a generalized fashion. وده بتخليني افكر فيها انها much less likely انها تكون epileptic. لو شاكك او مش متاكد 100%، عندي صديقي الحميم الاي اي جي بيقدر يوضح لي. فالهايبر اكبلاكسيا وبتتشاف طبعا في حالات كتيره، بس يعني اشهر حاجه في النيوناتال ايج النانكيتاريك هايبرجلايسينيميا. فالبيكتشر على فكره البيبي اللي انا وريته لحضراتكم اللي هو عنده fragmented myoclonic movements, that was more of a hyperepilepsy. That baby actually had a non-catatonic hyperglycemia. من الموفمنت بتاعه الهايبرإبلكسيا اللي هي بتبقى شكلها كانها fragmented myoclonic movements. من السيميولوجي او من الفيديو بقدر اعرف دي ايه. مش متاكد، الاي جي بياكد لي.
Another question, please, Prof.
Thank you very much, Professor Abdelmoity. We learned that we have subtle convulsion in neonates. Now you put a sector of motor automatism. How can we differentiate, or if you have a case of suspected subtle convulsion, we must do EEG to see if it is epileptic or not?
Yeah. So السؤال ده ممتاز جدا. زي ما ذكرت حضرتك احنا بدأنا الشغل ده في 2015 وانهيناه في 2018. 2017 the term subtle seizures راح يعني في ال classification ما فيش subtle seizures. ف you describe it either it's a brief tonic, it's a myoclonic. فعشان يبعدنا عن ال confusion او عدم المعرفة اللي بيحصل، فجت subcategorized تحت الموفمنت تايب بتاعته. فالسبل زي ما حكيت كتير جدا من الفيديوهات اللي وريتها لحضرتك كان very subtle. كان بي subtle focal clonic، كان بي subtle focal tonic، كان بي subtle myoclonic. فقبل كده كانت بتحط كلها in a waste basket او كلها في سله مع بعضها وبنسميها subtle. الترم subtle راح خلاص مش موجود من سنه 2017 مع الكلاسيفيكيشن الجديده. عشان كده انا استخدمت اللي انا بعتقد ان هو more accurate definition او more accurate description اوصف السيجر بالموفمنت بتاعتها. ودي على فكره ده مجرد توصيف سيميولوجي. التريتمنت هيكون واحد في النهايه طالما ان انا سميتها سيجرز، التريتمنت هيكون واحد في النهايه. ف subtle we didn't include it عشان خلاص راحت من 2017 قسمناها تحت different. الاوتوماتيزم لا، الاوتوماتيزم that's not a seizure. الاوتوماتيزم that's a non-epileptic event. السبل دلوقتي اتحطت تحت كذا كاتيجوري حسب النوع الموفمنت ايه.
شكرا.
تحت معاك.
Thanks very much, Professor Abdelmoity. Thanks so much.
شكرا، مع السلامه. السلام عليكم.
استاذه الدكتوره أمنية معلش انا هبتدي اشكر تاني من اول الدكتور حامد والدكتور سحر والدكتوره أمنية وكل حبايبي في البيدياتريك